Good afternoon, everybody. Thanks to Dr. Christie and the entire Arvind group for having me here. This is my first visit to Arvind Pondicherry. I must say I'm really floored by the hospitality. So I'm going to be speaking about infectious scleritis from suspicion to successful management. So the first thing is the incidence of infectious scleritis is about 5 to 10%. It's considered more in the Indian population. You can have a lot of predisposing factors like exogenous factors, which could be trauma or surgery. And organisms are in Indian population, many times it is bacteria or fungus, although you can have atypical mycobacteria and nocardia. And endogenous sources quite often can be tuberculosis, rarely syphilis or viral infections. We also have to remember that these patients are heavily immunocompromised, so there is always a possibility of associated HIV, and there is always the masquerade that you have to rule out before you diagnose an infectious scleritis. So let's look at this picture. You have a picture on the left, which is that of an infectious scleritis patient, and that on the right, which has a similar picture. The treatment of infectious is immune-mediated or immune-mediated infectious can really be very counterproductive. Therefore, you need to have a structured approach. So let's see how history is important. This is an obvious case. There is a joint deformity. There is a peripheral sclerokeratitis. You have immune-mediated disease in the peripheral cornea. So you have a reasonable idea that you're dealing with an immune-mediated disease. So it's important to rule out immune-mediated diseases in these eyes. But look at this patient. The picture on the left is that of a patient who has a very aggressive form of mucoepidermoid carcinoma, HIV negative, while that on the right is that of a patient who's HIV positive and has an aggressive scleral melt. So always keep the possibility of HIV in your mind. Now let's come to post-surgical cases. We'll deal with trauma and topical steroid use later. So this is a patient which we also published. This is a patient who underwent a graft melt for a staphyloma following trauma, but came with this presentation on day 3 or 4. As you can see, there is a central graft melt. This is obviously because the graft is not having a proper vascular cover, and because there is no vascular cover, the graft is melting, and this is non-infectious. So we went ahead and gave it a vascular cover, and this patient did well. So it's important to look at the patient carefully and look at the findings carefully. Again, very rare appearance of a patient who had a post-surgical, post-pterygium surgery with radiation melt. And this is a very important differential. As you can see here, this is a patient I operated 2 months ago. It was a clear-cut case for tumor. I did the excision, not much cryo, did minimum cryotherapy to the edges and the limbus, not to the sclera, but he came with a presentation like this. You see a very pale, bland sclera. It's important to rule out infection in these eyes, as you can see. The second most important thing, a cue that you will get from a SINS is that it happens in the area of surgical involvement, quite often after pterygium surgeries or VR procedures. And what is believed in literature is 70% of the patients do have systemic disorder that is being missed. So before you consider this as SINS, you have to rule out immune-mediated disorders by doing a blood test and then start treatment. This patient, we actually glued it and gave him topical steroids and immunomodulators, and patient did well. Now, next, let's move on to when do you suspect infection? If you really have somebody who has pain which is disproportionate to the clinical findings, please stop and think of whether you're dealing with an infection. So this is an obvious case. You have somebody who has a keratitis. If you look at carefully the AGR adjoining it, there is a scleral nodule. So most likely it's a spillover infection from the cornea. This was treated as fungal infection and viral infection. We scraped, we got nocardia, and we went ahead and did the treatment. Please remember, when you're treating the keratitis, also remember to deroof the sclera, because the scleral nodule is not going to just respond to topical treatment many times. The second kind of presentation is like this, where you have a classical pus point, so you know you're dealing with an infection. And the one on the right is that of a multifocal multinodular lesion, which is that of a nocardia, where you just scrape and get the organism and go ahead with your treatment. What about this case? This is a medical person. She's an anesthetist. She's been having a history of 3 months with diffuse scleritis, severe pain, started on topical steroids, oral steroids, immunomodulators, biologicals, and on fentanyl patch. She is not responding both clinically and symptom-wise. Here you have to stop and think of a differential of infective scleritis. We advised her biopsy, but she refused, and she came back in 2 weeks with an obvious pus point. This turned out to be a fungal scleritis. The fourth kind of presentation can be somebody like this. You have one which is fungus, one which is tuberculosis, and the other that is immune mediated. So how then are we going to distinguish one from the other? There are a few cues, although there can be overlap between infectious and non-infectious diseases. Age in elderly patients, the immune-mediated diseases are not very active, but you can have immunosuppression that can make them susceptible to infection. Of course, history of trauma or surgery, but like I said, we saw a case of fungal scleritis where there was no predisposing history of trauma or surgery. When you have pus points and multinodal involvement, please think of a case of a diagnosis of an infectious scleritis. Of course, when you have sterile infiltrates in the cornea or your systemic investigations are positive, you're going to possibly think of an immune-mediated disorder. Like I said, there can definitely be overlap between these. So when then do you consider a biopsy? When in doubt, always consider a biopsy. You can have somebody who's having no clinical response, symptom-wise worse, where you'll definitely consider a biopsy. On the contrary, sometimes you're putting these patients on steroids thinking it is immune-mediated, and there is a little bit response in terms of pain, but the clinical symptom is getting worse, sign is getting worse. Even in those cases, you have to consider biopsy. Let's look at some case examples. Here is a patient who's having a diffuse scleritis. All blood workup for immune-mediated disorder is negative. HRCT, QTB, chest X-ray, everything is negative. Patient on steroids, but progressively getting worse. Here you have to stop and consider a biopsy. What do you look for in a biopsy? You have to go by a clinical diagnosis, essentially do the test for all microbiological investigations, sometimes even unusual organisms like atypical mycobacteria or nocardia. And remember also to do a PCR, because sometimes you may not get a diagnosis in your scraping, but you may get a diagnosis with the PCR. I'll show one case example subsequently. And also remember to do histopathology. Send a sample to histopathology, because in cases with fungal scleritis and sometimes in tubercular scleritis, you can actually have the histopathology that can give you a clue to the diagnosis. So the investigations part we already dealt with. Depending on whether it's non-necrotizing or necrotizing or infective, you go ahead and do your systemic investigations. Now, this is a very obvious case where you need a biopsy. You see the patient has progressed from diffuse scleritis to a pus point, and then you do a biopsy and you get fungal scleritis. This was Fusarium that we treated. Now, what is the role of imaging in these eyes? As you can see, imaging may not clench the diagnosis for you, but it will help you when you have edema. It will tell you whether the edema is resolving or not to some extent over and above your clinical finding. Similarly, the picture on the right is of the SINS patient that I showed you, where you can see considerable thinning where we have glued. It will tell you whether the thinning is progressive or is it getting better. Next, let's see how do you do a biopsy. We have two scenarios. One is where you have a nodular lesion like this where you don't know what is going on. Here, you just open the conjunctiva, you reach the sclera, do minimal cautery, and then you try and see if you can do a partial thickness scleral graft as I'm doing here. And then you send the sample, like I said, to microbiology and pathology. And then close the conjunctiva. This is when you really don't have a pus point. Now, let's look at this case example. This patient has definitely a multifocal pus point involvement. The first thing you have to do here is examine the sclera in toto, because you will really have a lot of pockets of infective scleritis. Decide which one is going to give you maximum yield, number one. The second point, do not do the cautery initially, because cautery can actually mask the diagnosis. You may not get enough load of the organism in your microbiology. The third, do a deep biopsy, because many times organisms like fungus are sequestrated in the deeper sclera and not the superficial sclera. So you may not get a diagnosis if you're doing a superficial scleral biopsy. And last, send the sample to microbiology, and while you're doing the workup, see if you can get a diagnosis, because sometimes the subconjunctival irrigation can also be done with the appropriate antibiotic, and that definitely increases the result in terms of response to treatment, because you're actually increasing the local concentration of the medication. Let's move to management. Management has to be really aggressive, because a considerable amount of time has already been lost. You have to consider a combination of topical, systemic, and sometimes even intravenous antibiotics. Subpalpable lavage has been described. I do a lot of subconjunctival irrigation in these eyes. You have to remember to stop the steroids and immunosuppressives. And most importantly, there is a small role for ancillary treatment in terms of sterile grafts and sometimes cryotherapy, although you have to be very, very cautious, because you really want to do it when there's scleral exposure or risk of perforation, because when you do a patch graft, you don't know what's going on beneath it, and the infection can progressively get worse as well. So let's look at some of the organisms. Pseudomonas is the most common organism for infective scleritis. As far as Staphylococcus is concerned, many times it follows surgery, most commonly pterygium and Via procedures. In fungus, the diagnosis is usually very delayed. This is because the antifungals don't really penetrate the sclera and that considerable time is already lost because there are no obvious cues to the pointers of a fungal scleritis diagnosis. Nocardia again is one of the common organism post-surgery but has a very delayed presentation. And in viral is usually like in acanthamoeba scleritis, virus is usually an immune-mediated disease and you don't really have actual pointers unless there is posterior viral infection or sometimes you actually have anterior chamber findings that we already discussed in terms of keratic precipitates or increase in pressure that can tell you that you're dealing possibly with a viral infection. Let's look at some case examples regarding management. Patient who had a vitrectomy, high myope, did very well at glass appointment, was on topical steroids, came with very severe pain. First time the surgeon increased the topical steroid. Within 3 days, the pain was intolerable and was referred. On referral, we thought we saw very early pus points. We scraped. This in turn turned out to be Streptococcus pneumoniae. Please remember to do the sensitivity because sometimes it does help. We gave her topical and oral medications. She did not respond. She had intense pain, so we had to convert to IV antibiotics for a few days. And subsequently, she responded. She has a good follow-up of 2 years and had cataract surgery as well. So the lesson from this case is that post-surgery, if you see somebody with intolerable pain, please stop by and watch and see whether you're dealing with CINS or infective scleritis. Second case is what I discussed earlier. You have an obvious keratitis and a scleral nodule. Like I said, we scraped, we got nocardia. We started this patient on topical and oral medications. Patient did well. Remember also to do the de-roofing. Like I said, I like to do this local subconjunctival irrigation in the outpatient clinic because sometimes I feel it does increase the penetration of the medications to that area. So this was a straightforward case of diagnosis where she did well. We had a follow-up for 6 months with no recurrence of the infection. This is a patient that I already discussed, case that developed from diffuse scleritis to pus point over a period of 3 months, turned out to be a fungal scleritis. So we started this patient on topical oriconazole along with initial oral posaconazole followed by oriconazole. She required multiple de-roofings, multiple areas of pus points. She actually did well in 6 months. The lesson learned from this case is that you need not necessarily have trauma or surgery as your risk factor for infective scleritis, although 9 out of 10 cases you will have trauma or surgery as a risk factor. So what happens if you have somebody who is biopsy negative? This is another case of fungus. You have multinodularity, you are suspecting fungal, systemic investigation is negative. So if you still feel it is infective, patient is getting clinically worse, please go ahead and do a re-biopsy. That's what we did, and we actually found fungus in the second time, and we treated this patient, did reasonably well in terms of healing, although there's a lot of scleral thinning. Let's come to tuberculous scleritis. Tuberculous scleritis, as Radhika said, could be because of the organism or because of hypersensitivity response. It can present like this, like an ulcerative lesion with posterior segment involvement. But look at this patient. She presented with a diffuse nodular scleritis. Her QTB was positive, MAN2 negative, HRCT negative, but she did not take her anti-TB medications. When we did her biopsy, this is another point I want to highlight here, that sometimes the sclera alone may not be involved. She also had AC reaction, so we did AC test. The scleral biopsy was negative in histopathology as well. This could be because you're dealing with a paucibacillary variant. But the AC tab gave us information that this is actually a MTB, and we started her on anti-TB treatment. The chest physician started her on anti-TB treatment. But the one thing you have to remember about tuberculosis is sometimes you can have paradoxical response. This can either be because the treatment was initiated very late, or you have a lot of load in the eye, or because there is drug resistance to the organisms that you're dealing with, or sometimes when you start treatment and there's a lot of organism that is liberated, the inflammation that it causes can cause a paradoxical worsening, which is where sometimes steroids may be important and may play a role. Of course, this has to be decided by the chest physician. So how long do you continue? I think very important. We recently had a patient of pythium keratitis that was treated. Everything was fine. 6 months over. Patient was given mild dose of steroids, no recurrence at all because there was a mild inflammation. We saw a scleral nodule. In all possibility, we thought this was non-infective, but it did turn out to be infective. I really think in these eyes, you must do a biopsy or do a scraping and see if this is infective or not, because there are a lot of cases of late onset recurrences. So in bacteria, I would suggest you continue at least for 1 to 2 months following clinical resolution. But in fungus, you definitely want to consider it for much longer period to avoid the risk of recurrences. Posterior scleritis is a rare entity, mostly immunological. Rarely it can be tuberculosis or viral. I'm not going to go into the details of this. So I'm just going to conclude by saying that you have varied etiology and clinical presentations in infective scleritis, but many a times it is mistaken as a diagnosis of immune-mediated disease, even in the absence of your systemic investigations being negative. So you can have infective scleritis without trauma or in the absence of surgery as well. But if you have somebody who is worsening despite maximum treatment, you should definitely stop by and do a biopsy. If you start treatment early, you can go a long way in salvaging these eyes, both functionally and anatomically. Thank you once again for your patient listening.